All right, I think we'll go ahead and get started. My name is Kelly Michelson. I'm really excited to host this webinar, which is part of the Big Ten Augmented Intelligence Bowl webinar series that's hosted by I.AIM. Just as a quick point of introduction for those people who don't know, the mission of the Institute for Augmented Intelligence in Medicine is to bridge computational methods with human expertise to advance medical science and improve human health. I just want to point out that I.AIM encompasses a number of different components related to augmented intelligence in medicine, including bioethics and medical humanities. And that is really going to be the focus of our webinar today, but also has attention and centers focused on deep phenotyping and precision therapies, advanced molecular analysis, medical education and data science and digital health, computational imaging and signal analytics, as well as biomedical informatics and data scientists. I want to take a brief moment to thank our sponsors for their support of the Big Ten program and this webinar series, and they're listed here. And then before we get started, I just want to remind everyone that we'll be hosting the final event in the Big Ten, this Big Ten event, which happens October 22nd. And so please feel free to let people know about that and to share that information. We're very excited about it. Okay, so I'm really excited about today's discussion. We are privileged to have an incredible panelist today. Let me introduce Anita, and then we're going to have Dr. Ho, and we're going to have some time. She's going to do a talk, and then we'll have a period for Q&A. And so in preparation for that, I just want to remind people that as we're going along, if you have a question or a thought or something that you would like to have Dr. Ho address, please put it in the Q&A and we will try to get to as many questions as we can. So again, put it in the Q&A and not the chat function to help us have those questions in the same place. And without further ado, Dr. Anita Ho, I'm thrilled that you're here today. Dr. Ho is a bioethicist and health services researcher with a unique combined academic training and experience in philosophy and bioethics, as well as public health and business. She is currently an associate professor at the Center for Applied Ethics at the University of British Columbia and in the bioethics program at the University of California in San Francisco. She is a scientist at the Center for Health Evaluation and Outcome Sciences and the regional director of ethics in Northern California for Providence Health. Dr. Ho is an international scholar and author of more than 70 publications. Her research focuses on ethical dimensions of utilizing innovative and artificial intelligence technologies in healthcare, domestic and global health disparity, supportive decision-making, and end-of-life care decisions. She's currently completing a book manuscript on AI health monitoring ethics to be published by Oxford University Press, something we all need, and I look forward to reading. She is also working on a project as a fellow at the Emerson Collective on the use of digital monitoring during the COVID pandemic. And in addition to all of those amazing academic accolades, Dr. Ho is also an accomplished classically trained pianist, which I'm incredibly impressed by. So Dr. Ho, I will turn it over to you. Thank you.
Thank you so much for the very kind invitation and the introduction. I'm really excited to be here. As you can see that I'm wearing the purple color for your center as well. And so thank you again for being part of this. And I'm also very excited to read the proposals by the Big Ten teams and with the AI Big Bowl here. And so I want to see if there are ways that I may be able to also contribute some of the conversations as you are developing your models. So I'm going to share my screen now and for my slides, and I hope that you'll be able to see it. Maybe I just check to make sure that you are seeing my slides from the beginning. So maybe just let me know if it is playing.
Yes, we can see them.
Great, perfect. So the topic for today is augmented ethical intelligence for deep medicine. And as many of you know that there are many different ways that we can use the emerging technologies to help us to deliver healthcare in more efficient, effective kinds of ways. But there are also many different questions in terms of whether sometimes we actually have the right goals in mind when we are developing some of these models. Do we have the right people involved? Do we have the right processes involved? So in the next 20 minutes or so, I'm going to walk through some examples and use them to illustrate some of the ethical components as you are developing various models, look at your data sets, and think big ideas in terms of how you may be able to work on augmented intelligence projects and to help to think about healthcare delivery, particularly in relation to health disparity. So I saw this article a couple of years ago in The Guardian, and I was actually having a conversation with a friend of mine who is a physician, who's been talking quite a bit about some of her frustrations and concerns about patients who are not showing up for appointments. So now there are different algorithms out there that can help clinicians, clinics, health systems to predict whether a patient might show up for the appointment schedule. So there are many different questions that come up to my mind in terms of thinking about using algorithms to identify people who may be likely to skip appointments. And so one study that was done that was on the Guardian article that is being presented here was really thinking about how when patients are not showing up, for each patient that they are not coming, it might cost the health system around $5 US dollars. The question is partly about then how do we make sure that actually people will be showing up, or at least whatever slots that you have would not be empty, partly to make sure that you actually are using your resources in efficient kind of ways. So I just want to get us started here. So you can think about how these algorithms can have different purposes. They may be predicting different types of things as well. And I want you to keep this example in mind throughout the presentation today. But I would like to start out with a poll question here. It's a very simple question here. What do you think should be the primary goal of a no-show algorithm? I'm not sure if I'm actually able to pull that poll up here. Sorry about that. I can't see if the poll is actually up here or not, because I don't see a poll function there. Okay, great. So what do you think? Would it be to fill the empty slots? So airlines have done that, especially pre-COVID, that sometimes if you know that maybe about 10% of the people won't show up for the flight, you want to make sure that you will have enough people, so you overbook it by about 10%, so that in the end, you will have every slot being taken. Or do you think that the goal of the no-show algorithm is to provide assistance to get people who otherwise may not show up will come to their appointments? So is it more like just one or the other? I know that this is probably oversimplifying, but it may just get us a sense in terms of where we may be at. If there is a way to show the results, that would be great. Okay, so maybe I'm preaching to the choir here because we're talking about health disparity here. So it looks like everybody here who responded to this poll think that we should really use that. The goal is to really provide assistance to get people to the appointments. Now, why am I asking this question and getting us started here? Because depending on what exactly your goal is, what you might be predicting, what you may be measuring might be quite different. And so that may actually get us to really think about how do we actually think about building these augmented intelligence models. Would your goal be, for example, to promote the greatest good for the greatest number? Because that actually, in many ways, from an ethical perspective, seems like the right thing to do, particularly when we think about how do you actually allocate scarce medical resources. So this utilitarian theory or principle is often about maximizing the resource efficiency. So if you're worried that the slots may be empty and so that you may even have a longer waiting list later because some people didn't show up and people who want the slots are not taking the slots. So that may be one way to think about it. And in many ways, we're often thinking from a utilitarian perspective in how we manage or organize healthcare delivery. We want to make sure that we are promoting high value care, promoting better outcomes for less cost, if at all possible. And so in many ways, those are really good ethical and system goals as well. But there may be questions in terms of whether the utilitarian theory may sometimes compromise or neglect the rights or the interests of minorities. Because if we are trying to just promote the greatest good for the greatest number, what about those who are not in that bigger pool of people? Versus if we were thinking about how do we actually come up with the right goals for the right people, targeting the right people, for example, in relation to the no-show algorithm, that if you're really looking, for example, from a health disparity lens to see who are the people that are not showing up, what numbers are you trying to look at? And that may give you actually different types of insight, which may lead you to different types of decisions as well. Because when we think about augmented intelligence, you're using the data, you're using the learning from the data to help you to make various kinds of decisions. So if, depending on whose goal you're thinking about and what definition of the goal and the good that you're using, that may allow you to think differently in terms of what the fair resource allocation might be. So the example I was showing you in relation to the no-show algorithm, what the team did there in England was to look at MRI appointments to see whether people are showing up. It was quite interesting in terms of what they use and what they didn't use in categorizing patients who may not be showing up. For example, some of the data that they did not use in categorizing patients are including gender or ethnic backgrounds. Partly because even though they thought that that type of information may give them even more insight about who are the patients who are not showing up because of their electronic medical record platform, that it would be much more difficult for them to actually utilize the information. So that by itself already shows you that actually sometimes how we decide what information to use, how we are segmenting our populations may be depending on other kinds of reasons, but they may all have an impact in terms of what your result might be. So I think that from an ethical perspective, what we want to really think about is having the right goals, the right people, as well as the right processes every time when you're working on this. And what that would mean is also you want to have the right kind of thinking throughout the whole process as well. Partly because if we're not doing that, then there may be various kinds of paradoxes. We think AI can help us to do many different things, can help it to scale innovative technologies and good results. So the no-show algorithm may help us to do that, to really make sure that at a system level that we can really using all our clinic slots appropriately, effectively and efficiently. But at the same time, we may also sometimes be scaling the biases as well that may perpetuate some of the disparity that is already in the system. That particular algorithm showed that if they could identify no-shows correctly about 90% of the time. But at the same time, there were also people that they identified as potential no-shows that actually was incorrect. So there may be questions in terms of how can you actually mitigate some of these problems. Part of the reason why we need to be careful is that when we are scaling up the biases as well, we may also essentialize differences if we're not recognizing why, for example, some people are not showing up. What may be the social determinants of barriers that make it much more difficult for some people to be coming to the appointments. Other predictive tools have shown that, for example, there may be a gender difference. Men are more likely to show up in comparison to women, but it's not because of biological differences necessarily. There may be other kinds of socio-relational reasons why women, for example, if they're working from home, if they're working at the office or wherever they may be doing other kinds of paid employment, and they may also be caring for family members as well, that makes it sometimes much more difficult for them to even make it to their own appointments. So if we're only looking at who is not coming to the appointments without actually correcting some of those issues, that we may be essentializing the differences and simply assume certain differences among people. Big data may also have big problems for us. We sometimes think that the more data, the better. That may be the case, and that often is the case, but it also depends on the quality of your data and how you may be deciding what feature in the data would be relevant and important. As I mentioned in that NHS in England example about no-show, would gender, would other socioeconomic status, or availability of time slots for people who may be working during certain hours make a difference as well. So if we're not recognizing some of the contextual factors in terms of why or whether people are showing up, then we may be losing a lot of other kinds of insights. And when we're losing insight and we don't even recognize it because it's working 90% of the time, then we may be actually also confirming some of our biases. We may just assume that the data we have and the results that we have are objective enough, because 90% might be better than when we were not actually making any kind of prediction or correction at all. There are also times when we're so excited about using various kinds of technologies that we think that we can scale up and use it for lower resource settings. So that we may think that, for example, a no-show algorithm can allow us to use the data we have from academic centers to apply to smaller medical centers. But depending on whether your training data set and your target populations are really similar, there may be other kinds of problems as well. So this, I think, gets us to think about how do we set the right goals and have the right people in mind? What exactly are you trying to predict or capture? I like this background photo for Michael Porter's quote on how when you want to have a sound strategy, you really need to start with having the right goal. But sometimes if we're looking at a foggy area, we may actually not know exactly what the goal is. Having the right goal will help you to see what exactly are you going to predict and what you're going to do with that prediction. If you know that you can predict people who may not be showing up for the appointment, what exactly will you be doing with that information? I know that some of you are looking at vaccinations, whether it's childhood vaccination or COVID vaccination. If you are able to classify whether certain neighborhoods have lower vaccination rate, what exactly would you do with that information? Maybe in some ways, more importantly, is that the only thing that you need to know? Or are there other kinds of information that you still need to collect? So when you use your algorithm to sort patients and target care to those who are in need, you really need to have the right kind of goals, because that will really help to set you down the right path. But sometimes we also need to realize that some of the quote unquote neutral goals may actually still exacerbate disparity when we are not recognizing some of the social determinants of health as well. So what you wanted to also have is to make sure that you have the right people on your team when you're collecting the data, when you're thinking even through the problems that you are trying to address. How exactly are you creating or collecting the training data? Do you have a diverse team? Having a diverse team is not just about skin color, but maybe about other kinds of socioeconomic issues, ability, functional issues, and other differences as well. Sexual orientation may also make a difference in terms of whether people may trust certain kinds of healthcare settings and whether they would actually come to, for example, the appointments or not. You want to make sure that the training data is representative of different segments. And so you want to look at, is there overrepresentation or underrepresentation of certain populations? And who would be your target population in the end? Because you see on this picture that there are many different people that may have different interests, different concerns, and different priorities. Academic centers may be really good data if you are using your models for those centers, but we have to be also careful that it may not represent the rest of the population. So some of the higher profile examples that are already out there that you may have seen already is to see how sometimes that we may think a neutral tool, a new tool goal that we have, for example, in this case, to measure people's oxygen level in the blood using pulse oximeters. So a report in the New England Journal in the late 2020 showed that when we're using the same tools, very affordable tool for people with lighter skin versus darker skin, there's a higher error rate for people of darker skin. So now, if we didn't think about that, if we did not really segment the population to see when we are actually using these tools, whether it is having the same kind of error rates, then we may be going down a road that you may be exacerbating disparity. So in this study, they show that the error rate for people with darker skin is almost 3 times the rate of people of lighter skin. So more than, I think it's about 12% error rate when they use that on Black patients. Now, what does that mean in terms of the healthcare resource allocation and utilization? If we assume that the error rate is the same, then we may assume that whatever we are presented with will give us the right kind of indication in terms of people's health needs. So in this case, that they're actually underestimating Black patients who may have lower oxygen level, who may actually need healthcare immediately. And especially during COVID times, and when we are relying more on people using various kinds of at-home devices, this may really cast various kinds of problems for us. So we need to think about whether sometimes the quote-unquote neutral objective tools may actually have different impact on different populations. So what we really need to see is that even when you have the right goals, for example, in this case, is to measure oxygen level in people's blood, whether you are actually using the right kinds of tools. Other times you may have the right goals, but then when you are labeling your data, there may be a mismatch in terms of what you are using as the proxy and to measure what your goal might be. So some studies will show that you may have, or some algorithms have actually misdefined target. So which is a mismatch between the ideal target that you're trying to get the algorithm to predict and the proxy that you're using. So one study I will show you was trying to predict whether some people may have higher health needs in the future. And if they do, then we want to have various kinds of ways to target them and to provide support in advance. But if we don't have the acute awareness of various kinds of social determinants of people's future needs or past needs, then we may have a problem. This one study being presented by Obermeyer and colleagues that looked at how algorithms that are sometimes used very widely, even in various medical centers or insurance programs, may actually have some biases. So in this one algorithm, they were trying to use healthcare costs to predict what people's healthcare needs might be. So they assumed that people who were sicker and had higher health needs will continue to be needing them. But the way that they're using that is to see who has incurred more costs in the past. Now, one of the problems is that people who did not have adequate insurance may actually use healthcare less. As going back to the oximeter example, you can also imagine that if we have tools that were already inaccurate in identifying people's health risks, that they may also not be seeking healthcare because they thought that other tools that they were using was identifying them as being healthier. So in this case, using a proxy healthcare cost that may actually be misidentified would lead you to also other kinds of disparity problems. So in the time of COVID, we're really trying to promote more algorithmic ways of speeding up or making things more efficient. But there are also questions in terms of whether sometimes if we are not having the right models and the right processes, that we may actually continue to exacerbate various kinds of disparities. So depending on whether the models that you have are actually representative and that you're really using the right kinds of goals, these are certainly some concerns that we have to really be considering. Part of this question is because you have to really look at how we can be in a vicious cycle, ethically and clinically. So this is a chart that I find really helpful by Leslie and colleagues, and that came out in the British Medical Journal earlier this year. That depending on what the data sets that you have, if the data sets that you have already have some kind of baked in biases, because like I said earlier about how sometimes administrative data may show you some people are using healthcare less to start with. And if you use that as your data set, as your labels, that it may help to actually exacerbate some of these problems. So what might be some of the inequities already in the real world setting, and how might that be translating to the data sets that you have, how they may be labeled? If you're using, for example, natural language processing to look through clinical notes, and certain notes are using phrases like quote unquote non-compliance, and you use that to indicate whether somebody will actually be utilizing healthcare resources later on, that may also lead to various kinds of biases. So the data may, in the end, then lead to biased designs that when we're using that, we may also have unjust applications. And sometimes that you may have really good devices or good models, but again, if we don't also have much broader justice, much broader equity in terms of whether people can really utilize even that information, those devices, then we may be perpetuating some of the vicious circle and vicious cycle. So in closing, I know that I've gone through this very quickly and would be happy to go into more details. I think that we need to really think about how do we take human intelligence seriously. Many models can really help us to be more efficient and effective in our work. But sometimes if we are overly relying on models without knowing where the goals are and without knowing whether there may be various kinds of biases already built in, that we may be, like I said, exacerbating some of the inequities. That sometimes, ironically, it may be that when humans have to do the whole thinking on their own, that they may be more curious. So one thing that I would recommend is to really always have a curious mind when we're thinking through the whole process of developing your models, looking through your data to see, are we at the right place at every step of the way? When we think about building augmented intelligence, having useful and responsible tools to put humans first, one question that you may want to ask is which humans? Which humans are you using for your data set, for your training and your target populations? When we're leveraging data optimally for knowledge discovery and to improve health, whose health are we talking about? A utilitarian model versus a more egalitarian model, and coming from the lenses of health disparity will give us very different answers. Sometimes it might actually mean that we will have to use more resources for certain populations. So you need to really prepare by analyzing the health disparities in the clinical domains of interest, whether it's about vaccination, heart failure, monitoring, and so on. Why might there be health disparities in the first place? What may be some of the hidden or reasons that may actually not be in your data itself? And then review the training data for any kind of particular biases. Biases are not necessarily like a normatively negative thing, but recognizing what your data might tell you or not tell you about different populations would be helpful to see how you may be able to mitigate some of these problems. And then once you are deploying your models, how do you also monitor whether you have the same kind of health outcomes for different populations? Is the model performing equally well after you break it down for gender, ethnicity, sexual orientation, neighborhood, and so on and so forth? Because I think that we don't have that post-deployment monitoring, then we may be reconfirming our own biases to start with. We may think 90% is really good already, and then missing the 10% who might actually have been historically already marginalized and left out in some of the healthcare participation. So back to the no-show, one thing that you may want to think about is, again, if we are using only a model or the goal of filling empty slots, we may actually have a self-fulfilling prophecy. In my conversation with my colleague who was talking to me about their frustration regarding patients who are not showing up, one of the questions that I asked is, what do you do when you overbook and then the patient that you thought didn't show up now is here? And the person said, well, of course, and they are even more angry. Sometimes actually, ironically, they may leave because they think that you already gave my slot away to somebody else. So that may actually have a self-fulfilling prophecy. Then you're assuming people don't show up, but when they show up, they're not being seen, or they now have to wait for longer because of the overbooking. And then actually that may perpetuate distrust that makes some people even less likely to return to the clinic in the first place. So we want to be really careful how, when we are setting up various kinds of models, that we're not actually perpetuating some of the disparity and maybe contributing to that disparity as well. Thank you.
Thank you so much, Dr. Ho, for that wonderful presentation. I really appreciate your insights on everything, and I'm looking forward to some discussion about what you brought up. I have a couple questions for myself, but I want to just encourage the group, if you have any questions for Dr. Ho, or if something comes up as we're chatting, please go ahead and put them in the Q&A box. But I guess I'll start by just thinking about, I think this is crucially important, that when we consider the impact of bias and the ethical challenges posed by AI, that we really start at the ground, and that it needs to be as far down as what actually is the purpose of what we're going to move forward in developing, which I think was one of the themes that I heard from your talk. And I wonder if you could help us think, particularly as we have a group of people getting into this field, working to develop their own research projects, their own AI objectives and goals, how can they think about, from that ground level, creating goals that meet the needs of, meet appropriately, ethically balanced, unbiased needs?
That's a huge question, but it's a great one. I think especially for participants who are in the competition in terms of thinking about health disparity. I think the first question I often would ask, and when we say having the right goal, is why are you even interested in a particular model or particular clinical issue in the first place? People enter medical school usually because they want to help, but they might have different approaches in terms of what types of populations or what type of conditions they are most interested in. So I'm generally most interested in health disparity issues. So the lens that I'm taking might be quite different. And so I think that one of the questions that we really want to look at is what exactly may be some of the social determinants of the differences to start with. So I know that some people are looking at heart failure or vaccination. Using vaccination as an example, if you're really trying to think about promoting higher vaccination rate, you really want to start by thinking about why might there be different types of populations who are not able to get vaccinated or more reluctant. So I know one team is looking at childhood vaccination, about mobile vaccination. Pharmacy deserts may be one reason. The lack of trust in the healthcare system may be another reason. So if we have more of the qualitative data as well, not just vaccination rate or not just zip code to show us who may or may not be going, will really help us to enrich some of the thinking in terms of what may be the barriers. The numbers tell us some things, but they may not tell us the whole story. So I would certainly encourage thinking much more broadly about some of the basic contextual factors as well.
Great. And we're actually getting a number of questions. So I am gonna kind of move to some of the questions that people have been posing. And just really, one person asks about how you think that biases could be mitigated, particularly those that relate to algorithms developed by third parties. So maybe here, moving from the goal to some of the implementation.
That's a really good question. So in terms of mitigating, I think that we should always use third-party applications and models with due care, especially if you're not able to know what training data set was actually used. So there have been a lot of push now from a regulatory perspective, but also voluntarily, to say that when we have algorithms, when we have models, that we want to know from a modeling perspective, what was the training population? This actually has been a question that many have been asking in terms of the transparency about some of the models or transparency about training data. If you're using third-party models that you don't actually know whom was it being actually trained on. I think that you really have to be very careful. And if you are using that, then this is really definitely an audit that would be helping you to give various kinds of answers as well. That when you're using the model for different populations, are they actually working equally well? And if not, what would be the mitigation strategy? I often think that before we start using a kind of tool, especially a tool that you don't really know very well, you always have to think about how would you be monitoring that throughout the process that you're using it, and what may be the worst case scenario. Sometimes knowing what the worst case scenario might be would allow you to start really tracking what some potential problems may be, and then to stop that earlier on.
Thank you. And I kind of want to build on that. And also another question, as you talked about goals, I was thinking about a lot of the private organizations that or companies that are working in the space of AI and healthcare. Big groups like Google, Microsoft, pharma. And I guess I'm curious your thoughts about how those organizations might be encouraged to identify goals and really be highly critical of both the goals and the technology itself with respect to AI. And I think this builds a little bit on a question here in the box from Mark Shapiro about current regulatory efforts in AI, and do those just apply, who do those apply to, and how does pharma and other companies outside of academia who may not be motivated in the same way to think about all this stuff?
That's a really good question, and partly because when you think about the FDA, the Food and Drug Administration, they would be approving applications that may be considered to be medical devices. But not everything would be considered to be medical devices. So it depends on how particular companies are trying to develop and market their products. So my first degree was in marketing, and so I often think from different lenses as well. So devices, if it is on your watch or other kinds of smart devices, if you are trying to say that this is actually more of a recreational or wellness device, you don't have to be getting FDA approval, which means that it allows you much more flexibility. But at the same time, there is also the danger there, because depending on how some of these are being marketed, you may have, for example, the other kinds of trade regulations that will apply to say that you cannot make deceptive claims. But that doesn't have to actually show you that your devices really have any kind of medical or real clinical values. So one study, I didn't cite it in here in my talk earlier, there was a systematic review, a rapid systematic review that looked at more than 100 applications for COVID in the last year or so, that all promise various kinds of predictive value for prevention to detection and so on and so forth. At the end of that article, the authors show that actually because many of these models were biased, that none of them at the time of publication, this would be probably about 3-4 months ago, none of them actually currently should be applied clinically yet. So I think that really raises various kinds of questions in terms of how do we actually think that we can use these applications in a very fast way without recognizing what may be the situation in the longer term and who the populations that you may be working with. I want to say one thing about big companies, and I don't want to name companies here, but big companies that are using different kinds of devices. There is also a major digital divide, rural versus urban areas, older adults versus younger people. So some people may have much better sense of using some of these applications. Others really want to have more of the human contact and human monitoring. And so how do we also reconcile some of this as well? You're using smart devices to track various kinds of things, but that those devices are actually not reaching certain populations. The data you'll be collecting and the data you'll be using would be automatically inherently biased. And so when the data isn't being shared and the data sets are being shared and being merged with other data sets, then they may already be that particular level of biases that we would have to think about how do we mitigate.
Yeah, really a lot of levels to think about. The example that you gave about COVID and the sort of prediction models is really interesting to me. And I have to say, as an intensivist who lives by the pulse ox, I was struck by that piece about discrepancies in pulse ox readings. And it just makes me feel like there's a lot of things that we do that we feel like that we believe there are data to support that are kind of, hard facts. When I put the pulse ox on someone and it says 97, I think that's what their percent saturation is, but not so much. And there is not always the case. And I imagine the predictors of a lot of these outcomes for patients with COVID also sort of felt like they had a good strategy. And one of the challenges that all of this brings up is kind of understanding what we don't know, identifying what we don't know, and thinking about proactively ensuring that we are mitigating biases. And do you have any thoughts about that piece of it? How do we know what we don't know, and kind of think ahead of even the technology in some way to understand that better?
Well, I want to make a point about what we don't know. The pulse oximeter example, some people have actually pointed out, and including the group that did that published that correspondence in the New England Journal of Medicine, actually pointed out that this was something that was already known, in the sense that there are studies in the literature that actually show that they have not been as effective or as accurate for certain populations. But COVID certainly made it, I guess, amplify that, because especially when people had to stay home, and then these devices are relatively cheap and they're buying them at home, and that's how we know. So sometimes we don't know, partly because I think we're not curious enough because of our own internal biases. And that's why I mentioned earlier that if you have a much more diverse team and really think about the devices as possibly helping you rather than relying on them, that may be one of the really important lessons for ourselves. One thing to also remember too is we may think that some of the devices we're using, including the pulse oximeter, that's one thing, that we actually have other, we may use the scans, we may use other kinds of blood tests to merge different or compare different information to see whether that is actually accurate or not. But we also have to realize that sometimes it starts the motion. It starts, when like you said, you saw that the patient's oxygen level is, if the person is in, mid to high 90s, you're not concerned, then some of these other tests may not be ordered. And so it's really recognizing that not only should we be thinking about using the quantified information, but patients' narratives, patients' complaints, and patients' own subjective experience, we really have to take it very seriously. One concern that I have is that when we are using more of the quantified self, that we think that can really replace patients' own experiences, that we may sometimes distrust the patient more. So from an ethical perspective, I think that this is the time when we really have to make sure that we are not dismissing patient voices because we are over-relying on what we think would be the accurate data. So at least, that part is something that we really need to watch for.
So I wonder if I could build a little bit on that idea of diverse teams and not dismissing patient voices. And a lot of those ideas bring to mind a strategy for doing research called community-based participatory research. And I wonder if you think that there are approaches to doing research in this field that could borrow from that strategy of community-based participatory research.
That's a wonderful idea. And I think that some projects may have, for example, a community advisory board that may be also very helpful for you to think about whether the model that you're trying to build, the health problems that you're trying to consider or to address really is the main concern of your community. And so knowing that first would really be helpful. And then to also then have people who may help you to have a more critical lens, because sometimes as we get into it and we are so excited about the data that we have, that we think that we have all the answers. And so absolutely, I think that having the community-based advisory board or more people being involved, perhaps also more people from different disciplines involved, can also really help us to think about how there are different lenses. So I mentioned earlier in relation to no-show, I'm not as concerned, of course, about the 90% accuracy in those situations from that number perspective. I'm very concerned about situations that are not accurate, but I also want to know is that when we have the numbers, when we say, well, it is very accurate. And so if we know that people from certain population groups are not showing up, and then we will just fill those slots, you are not correcting the health disparity. Your goals would be very different. But if you have an advisory board, if you have a community-based methodology for your research, you would know that you need to really tweak your research question in the first place.
Yeah, you know, another thing that's come to my mind as you're talking about this is, I'm kind of switching back a little bit to well, hold on, I'm gonna pivot because someone had a question that I think they wanted answered. So let me attend to that. So someone wanted to know about the role of consent of patients to having AI tools used in their healthcare decision-making. In your no-show example, should those patients have been required to consent to having the AI tool used on them? Let's focus on consent. That's a really important topic. So thank you for that question.
That's a great question. And so when you think about what do patients know that is happening behind the scene, should patients know that AI is being used to predict no-show? Should we know that AI is actually being used to arrange or schedule people? Probably, I would say that, yeah, in a really good way of thinking about ethical consent, it sounds like the simple answer would be yes. But there are many other automated processes that we are already using that patients have really no control over already. So I think sometimes it's not necessarily just about consenting to the tool itself. Consent does not do as much, I think, for us as we might think, because I don't actually know what would the answer be. So if a patient says, no, I don't want AI tool to be used for scheduling me or my slot, or that I as a patient would say no to the clinic using the tool. So consent doesn't have the same kind of power as we might think it does. Now, you might say that, well, maybe I don't want to use the oximeter as the only tool possible. But do patients actually, generally speaking, have that kind of options to say, I want other kinds of blood tests or other kinds of imaging to really confirm or dispute my symptoms or my complaints? And so I think that question really raises other important considerations as well. Consent allows us in some ways to make informed decisions and to say no to certain things, but consent, I don't think actually at a health system level really helps us as much as we think.
Yeah, I agree. And I think that in particular, frankly, there's a practicality aspect to consent that's important to consider. When an individual goes to receive care, their information is available for a lot of different kinds of research that I think many patients may not be aware of, that could be conducted without their consent, in part because there are important questions that we couldn't answer if we had to go through the practical exercise, or not practical, but the exercise of asking every person for their consent and for the specific restrictions related to that consent. Maybe some people are okay if you use my my age and my birth date and what disease I have, but not okay if you use other information about me. And we don't do that currently. There's a lot of work that goes on behind the scenes. And I'm a little bit reminded actually of when I teach research ethics, and I teach about the Beecher article, which talked, in 1966 about research that was done, which many would consider unethical these days, and has led to a lot of the regulations that we see in clinical research. But many argue that Beecher, who wrote that article, actually felt like the researchers themselves have an important moral obligation, if you will, to do ethically sound research, and that we as a community should be regulating ourselves in that way, that we should be driven by these sort of high moral principles and do the right thing. And I guess I'm wondering about that blend of like, how much should we as clinicians, as researchers, as future scientists, I mean, the people on this call are the ones that are going to be changing the world for us over the next decades. How do we encourage consideration of all these things? Do we need regulation? Does it come from us? How do we find that balance?
We may need regulations, but I don't think the regulations can really do everything for us either. So consent, I mean, you mentioned about consent. Should people, like in research, should people be consenting to research and have the option to refuse? And the answer generally would be yes. But there's also questions about like a learning health system. So for example, Kelly, you mentioned that, which I think is really interesting. What if I say that, okay, sure, you can share certain information of mine that is more quantified information, but I don't want my gender, I don't want my profession, neighborhood, and all these other things being reported. But now you may have data sets that have these gaps. So then what would that mean, right? So in many ways, we may have to ask the question in terms of how do we actually build a trustworthy learning system, health learning system, so that, of course, you may still want to say that patients should have at least the information or knowledge of what kinds of research might be being done. But the individual consent model does not necessarily actually help us to answer questions about whether we have a system that is respectful of people. Even patients who said that, well, if I have the option to opt out, I don't want to be part of this research. That by itself doesn't actually solve issues about the system. I would be more curious to see why some people might be much more hesitant in contributing to research or in having their data being part of a data set for AI development or other kinds of research development. Consent plays certain roles, but consent cannot be the only thing. And so you really have to think about not just regulations, but how do we actually have trust? And so people think about data, more about data security. And also, if you take my data, is it really going to be used in ethical kinds of ways? Is it actually going to be used for good? And so many patients or research participants are actually quite willing to participate, but they also don't know, are they the ones or their communities going to be benefiting? Because if we are contributing the data and our community actually in the end will not be able to afford the smart devices that you are producing, then what is the point? And then they may feel that there is a sense of exploitation. Consent is not going to replace some of these considerations.
Yeah, it's kind of a complicated conundrum, for sure. Well, in the interest of trying to get to all the questions in the Q&A, and maybe this will take us full circle as we are wrapping up here, someone asked about whether this use of the case that you presented about in terms of appointment scheduling, how prevalent is that? And are we seeing in that case differences in terms of where people live? Is there a way maybe you could address that and kind of bring us to a full circle conclusion about the conversation today.
Yeah, it may be a full circle of non-answer actually in some ways, but it may actually get to some of the questions being asked. It's very difficult to get the answer to that because places are using some of these algorithms are not telling the patients, so go back to that consent question, they're not telling the patients that they're actually using it. So you can look up, you can look up actually online some of these models that are being used. They don't tell you necessarily what the breakdown of the segments might be. And even that NHS example that I was presenting, that they decided not to segment the population for with certain demographic information, partly because it did not fit with their EMR. So it's really difficult in the end to do the audit to see, are you then in the end benefiting or disadvantaging certain populations more, which is why I think that having that audit to see if you are using this tool along the way at various times, how do you actually show what the segments of the society might be benefiting from it? And of course, one thing that also is important for us, especially when we're talking about segments, is are you labeling the data set actually accurately? Because we may be also sometimes lumping different populations under certain labels that may also then lead us to different answers than what it may really be. So it's a very big question and a very important one, but that's why I think that having an audit trail from the beginning to, there's no end, right? Because if you continue to use it, then you should always be tracking what the impact might be on different populations.
Great. Well, I see we're kind of at the top of the hour. I want to just thank you again, Dr. Ho, for your really fascinating, important presentation and for giving us a chance to have this conversation. And for everyone who attended, thank you so much for your questions. And I hope everyone has a great day.